Neoadjuvant therapy. Introduction. Neoadjuvant therapy refers to the treatment given before the primary treatment, typically surgery, in patients with certain cancers. The primary goal of neoadjuvant therapy is to shrink tumors, making them easier to remove surgically and to improve long-term outcomes such as survival rates. Neoadjuvant therapy may include chemotherapy, radiation therapy, hormone therapy, targeted therapy, or immunotherapy, depending on the type and stage of cancer. It has become a critical component of cancer management, particularly in locally advanced or borderline resectable cancers. Purpose and goals. 1. Tumor downstaging. Neoadjuvant therapy aims to reduce the size of the tumor, making it operable or allowing for less extensive surgery. 2. Pathological response assessment. It provides an opportunity to assess the tumor's response to treatment, offering prognostic insights. 3. Control of micrometastases. By targeting cancer cells throughout the body early, it helps to control or eliminate micrometastases that might not yet be detectable. 4. Preservation of organs. In some cases, neoadjuvant therapy may allow for organ-preserving surgeries, enhancing the patient's quality of life. Improved outcomes. By reducing tumor burden before surgery, it may enhance the chances of complete resection and improve survival rates. Types of neoadjuvant therapy. 1. Neoadjuvant chemotherapy uses cytotoxic drugs to shrink the tumor. Common in cancers like breast cancer, esophageal cancer, and bladder cancer. Example, anthracyclines and taxanes in breast cancer. 2. Neoadjuvant radiation therapy. Focused radiation is used to reduce tumor size or sterilize the surgical margins, often combined with chemotherapy in cancers such as rectal and esophageal cancers. 3. Neoadjuvant hormonal therapy, used in hormone-sensitive cancers such as breast and prostate cancer. Example, tamoxifen or aromatase inhibitors in estrogen receptor-positive breast cancer. 4. Neoadjuvant targeted therapy involves drugs that target specific molecules or pathways involved in cancer growth. Example, HER2-targeted agents like trastuzumab in HER2-positive breast cancer. 5. Neoadjuvant immunotherapy enhances the body's immune response to fight cancer. Example, immune checkpoint inhibitors in certain types of lung cancer or melanoma. Indications. Locally advanced tumors, when the tumor is not initially resectable but could become so after therapy. Borderline resectable tumors, tumors that might be resectable but with a high risk of positive margins. Organ preservation. In cancers where surgery might involve loss of function or disfigurement, such as laryngeal cancer. Aggressive tumors. For aggressive cancer subtypes to assess their chemosensitivity or radiosensitivity. Advantages. 1. Facilitates surgery, makes previously inoperable tumors resectable. 2. Reduces recurrence rates, eliminates micrometastatic disease early in the treatment course. 3. Personalized therapy, allows clinicians to modify post-surgical treatment based on the tumor's response to neoadjuvant therapy. 4. Improves organ function. By shrinking tumors, less extensive surgery may be needed, preserving organ function. 5. Predictive insights. Tumor response helps predict prognosis and guides further treatment. Disadvantages. 1. Delayed surgery. In some cases, surgery might be postponed while administering neoadjuvant therapy. 2. Toxicity. Patients may experience side effects such as nausea, fatigue, or organ-specific toxicity. 3. Risk of progression. If the tumor does not respond, it may grow or metastasize during therapy. 4. Non-resectable outcome. Poor response could leave the tumor unresectable despite therapy. Assessment of response. The success of neoadjuvant therapy is evaluated through 1. Imaging, MRI, CT scans, or PET scans to measure changes in tumor size. 2. Pathological examination. Tumor samples from surgery are examined to assess residual cancer cells and calculate the pathological complete response (PCR) rate. 3. Biomarkers. Monitoring tumor markers or molecular changes indicative of response. Examples in clinical practice. 1. Breast cancer. Neoadjuvant chemotherapy with agents like anthracyclines and taxanes is commonly used. HER2-positive cancers benefit from trastuzumab and pertuzumab as targeted therapy. 2. Rectal cancer. Combined neoadjuvant chemoradiation improves surgical outcomes and reduces recurrence. 3. Esophageal cancer. Chemoradiation before surgery enhances survival and improves resection rates. 4. Lung cancer. Neoadjuvant immunotherapy combined with chemotherapy shows promise in non-small cell lung cancer. Complications. While effective, neoadjuvant therapy can lead to toxicity, chemotherapy or radiation-induced organ dysfunction, tumor resistance. Some tumors may not respond, leading to progression. Surgical challenges. Extensive fibrosis after therapy may complicate surgery. Future perspectives. Advancements in neoadjuvant therapy are focused on 1. Precision medicine, developing therapies based on genetic and molecular profiling of tumors. 2. Combination regimens, integrating immunotherapy with conventional chemotherapy and targeted agents. 3. Real-time monitoring, using liquid biopsies and advanced imaging to monitor response. 4. Expansion of indications, exploring neoadjuvant approaches in more cancer types, including pancreatic and ovarian cancers. Conclusion. Neoadjuvant therapy is an evolving and powerful tool in modern oncology. By addressing tumors early in the treatment process, it offers the potential for improved surgical outcomes, better survival rates, and a deeper understanding of tumor biology. However, its success depends on careful patient selection, multidisciplinary coordination, and ongoing advancements in therapeutic strategies.